One other thing I forgot to mention that Gary pointed out to me, all metals should be off the body, especially glasses, which is metal crossing the midline, which will prevent you from detecting any type of switching, because it itself corrects the switching.
Partial.
Yeah. Well, preferably, yeah.
In the case of a metal plate in the head, or
to take the head off.
or in bridges, I've used strip magnets covering the length of it, and that'll neutralize it.
Thanks. Next muscle is the gluteus medius muscle. The patient has to lie down for that one. It's a straight abduction of the leg. You keep one leg in a straight down position, one leg abducted to the side. Yeah, and not up like you're doing it over there. It's a tensor fasciae latae, which is again a different muscle. So you want to have it straight in the plane of the floor to the side, and then push the leg in. Okay, everyone try to get that particular muscle. And again, like the most important issue is here to learn how much resistance this particular patient is giving you, what is normal for him, so that you can detect changes around that normal value.
I just want to see where you are in the career.
Okay, let me give you one more muscle. One other muscle. Now, if you find both of these weak to start with, and I'll give you three muscles because there's usually all you need. They all relate to three different systems in the body, and one of them usually is strong as long as your patient is still alive. The other one is lying prone on a prone position, and that's a piriformis muscle. Now I'm going to demonstrate that one quickly up here. The leg bent 90 degrees and the foot brought over like this, and then you pull back like this. And this is the one that I use in very strong people, like weightlifters and stuff. That's the one that they can't, or people that are very ambitious, like Germans. Muscle testing on Germans is almost impossible because they give it so much effort in being strong, and it's not a matter of that. It's a matter of the patient giving you approximately the same amount of resistance every time, but not trying to demonstrate how strong he is. If you have a patient like this, you use the piriformis muscle. It's pulling the leg straight out like this. By bridging against the other one. I want all of you to do that quickly, to just keep those three firm in your hold, those in your mind.
Resist.
Try you.
You want left one? Can you test to see if it was wrong?
Yeah, I do for quickies if it's going to be short, but the deltoid weakens so quickly. The other muscle pattern you see each one, that's what you can feel what you're doing.
Okay, one hand has to be on the opposite leg to brace yourself against the pull of the patient. One hand is, that's it. One hand on the ankle of the leg that you're testing, and one approximately on the knee of the other leg.
Can we do the fingers separately? When he's doing the legs, I do one
You have
and
to
the
do
other.
them separately.
Separately? Oh, really? Just got myself free.
I was doing it separately.
Okay, let's go back to the seats. I wanted to just give you an idea, sort of, if you start doing this on your patients regularly. This is a thing that, of course, you get good at with experience. The surrogate testing that I showed to you is much easier than the testing on the actual patient. If you have a nurse or somebody in your office who is fairly sensitive and leads a fairly balanced life, those are the ideal people to use as a surrogate. Terrible people to use as a surrogate are husbands and wives and children, direct blood relatives of the person you want to test. Since we're working at the muscle testing, one last comment I like to make to teach you how to test for medication. because this is so commonly, like we had these whole lectures over the last few days talking about the homeopathics, of how to test for homeopathics. And there is really only one way that works very, very beautifully, and I like to demonstrate that, even though that's not really part of my presentation here. And if you don't mind, I'm going to use you as a subject for this. For testing for, and I'm going to use it here for the testing of the local anesthetics and the bee venom, because we're going to be injecting him if he lets me. So I'm going to first demonstrate to you how I test if the person is going to be allergic to the medication or not. And to do that, you need a little round or square metal plate, preferably out of brass, but any other metal will work, but if you have brass, it's really the best one. And let me quickly find something of that shape.
What about this?
It's too small.
Metal plate,
Metal plate. You have over here.
here we are.
No, it needs to be about this size.
Here, how about this?
Oh, the lid?
Yeah, well, that is too small.
Is that a metal lid on
That'd be great.
that package right there?
No, it's plastic.
Well, I think, Gary, we need to use your microphone.
Gary, what about that Zollicane can? Plastic. Is that plastic? How about your badge there?
Yeah, how about this badge? It's got information printed on it.
Is it? Well,
They'll
it's
never
really
pick up
small.
a handpiece and use
I
it.
think this is pretty ideal here. Let me use this.
Okay.
Okay, why don't you lie down on your back? So the first demonstration I'm going to give is with testing his watch, whether his watch, like most watches, is bad for him or not. Okay, hold it. Okay, little better. Okay, now the idea is with the metal plate, you put this on the acupuncture point, spleen 21, and by doing that we weaken his system. And this is also how we can learn in any given patient of what it would feel like to weaken him. Like if you do the scar testing, it's a good test to do first to learn in this particular patient what is strong and what is weak. And you need to find the difference, of which sometimes can be very fine. So spleen 21 sits here underneath the shoulder, and you just kind of have him tug it in like this. Now, this may additionally weaken him, the wiring. Okay, hold it. And it gives a very distinct weak feeling. This is a good way to learn in each patient what is their strong and what is their weak, if you're not sure
This
with the other
energy
testing
drain.
what it is. It's an energy, we're basically draining his energy. Now we're checking of, like now I'm going to test his watch and see what that's doing in addition to him. Hold it. And it's further weakening him. Now I'm going to give him my Tesla watch just to see if that would make any difference. Sometimes it does, sometimes it doesn't. Hold it. Does make a big difference. I don't know. You probably notice it. Makes a huge difference in him.
Put it back.
Hmm?
Put his watch back on.
What?
No, his other watch.
Oh,
His watch. His watch. That was dramatic change.
yeah. Yeah, it is, and that's why most people walk out of my office with one of these watches.
He also gets a piece of that.
No, I'm not. No, it's one of the rules I have. I'm not selling it myself, but I have a card of somebody who is selling them in town, and they're difficult to get. They're about 140 bucks. Okay, hold it. Yeah, that's kind of. Yeah, you just can't maintain the strength, you know, and this is a very distinct, a big difference. We're not looking for any airy-fairy kind of slight, maybe, change. We're looking for a big, tangible change that you don't have to be a psychic or a born whatever to feel. We're looking for a big change. And the same way we're testing now the local anesthetics, with him already being weakened by this, We're looking for the local anesthetic that preferably strengthens him, or at least no further weakens him. So I got 3 choices here. Of course, we don't know what the TV screen is doing. It may scramble some of the information that we're getting. So we go back and testing again. Hold it. I have a Novocaine here without preservatives that I just put on him. Hold it. That's not getting him strong. And you have a lidocaine here. Hold it. That is getting him strong. Do you feel the difference?
Yeah, I mean, I have a hard time deciding whether you're pushing differently, but
See, that makes a difference if he holds it in his hand. In his hand.
in my hand.
There is, when you do this a lot, it's just like with the Vega test and with the Mora machine also, there is that effect when you touch a patient, you're in his energy field, and it's weakening you too. And you will be pushing less hard. If you would measure my strength that I push, I would push less too, and sometimes the people feel and get very insecure, well, is he making that up or not? But what you're doing is, your intention is pushing the same hard that you do every time. But your intention is weakening, as your energy field is weakening by getting in his energy field, and that's probably what you're sensing.
Really?
But the sensation, the combined result is a very clear sensation in the examiner of a weakening. Hold it. And it's getting him very weak, so I could almost with certainty predict that you're allergic to Novocaine, if you never had it. But, we treat people that have been, ending up in the emergency room with hyperacute allergic reactions to local anesthetics. And I've been using this to find out the one that we can use. And it takes some guts and some trust in this procedure to then go and inject them. And has not worked. So, okay, hold it. It's a very distinct difference. Yeah. And in this case, hold it. Yeah. This is Serapin, which is a wonderful American local anesthetic that no one knows. It's an extract from the purple pitcher plant. It's in a PDR. It's a local anesthetic that selectively numbs pain fibers, and that for very long, for 24 hours. And for all my spinal injections close to the spine, I use this for treatment of low back pain, or for any treatment in the gluteus medius or piriformis area. It is the best modality that we have for that, much better than any of the other local anesthetics. And I would like for you guys to start using that.
What's the name?
Serapin. You can look at it later on. We're going to have it sitting here.
Does it come in carpules or multi-dose?
No, only multi-dose bottle. They had an epidural grade one that I used for epidural injections, which was wonderful, but it wasn't sold enough, so they stopped doing that one. There hasn't been one allergic reaction recorded in the history of this medication.
There's been death recorded.
Of course.
Using it with an epidural.
In an epidural, really?
What's the reference on that?
What kind of impurity did you say?
Well, I don't know. It's a personal friend of Dietrich's and mine, and I don't know if I want to expose it on tape.
That was
But there is death with Serapin reported. Again, I'm going to emphasize, if you're going to do epidurals, only use spinal grade substances, period.
I'm glad you
Fabulous
used
results with epidurals.
So it's not in the literature.
Well, I put it in my book to do it.
So it
there
is
has
in the
been
literature
death.
now.
Anesthesiologists can verify with other substances.
But
there
is
has
it,
been
you
death.
know, a literature reference that you can give us?
Well, that's a court case.
But anyway, I'd like to.
On the death with Serapin.
Yeah, that was the famous epidural we know about in Arizona.
Yeah.
Yeah.
You're on.
Yeah. I didn't know that was Serapin. In the PDR, according to the literature, there hasn't been any single allergic reaction. You probably know that. And so that's
multiple dose lidocaine that I've had 100 times.
Yeah. Well, anyway, this is why I'm proposing to you to use the muscle testing, no matter what the literature says, because there's always going to be a first time, and I'm not anymore using it, epidurally. I used to use it and liked it a lot. But this is very, very good if you treat muscles, trigger points, or any place close to the spine. It saves you from having to use steroids. If you use paravertebral blocks, or facet joint injections, or injection into the sacroiliac area, this is the way to go. I mix it 50-50 with 0.5% lidocaine, and just really have dramatically improved the results from it. And I don't know if you work with Serapin, but it's a wonderful wonderful substance. And I've never had any reactions from it. I've never had anyone not test positive, in the testing, or very rarely somebody tested a little bit iffy with it. So it seems to be universally very, very well accepted by people. Okay, do you have that with the medication testing? You can test your homeopathics like this. There's also testing for the dosage, which I don't want to go into today because that's going a little bit over the framework of this course. But if you have this, you take a brass plate, put it under the axilla here. Look on your acupuncture charts or buy one where the spleen 21 is. It has to cover that point if you're not sure at which position. And use something big enough to get that particular patient weak. I have different plates in my office that I use. Very sensitive people, you can just have something this size. If somebody is, drinks a lot and smokes a lot and drives a truck, you're more likely to need something bigger to get a stronger weakening effect. And then you put your homeopathics in until you find the one that gets him strong. And you know that that's going to make a difference in how this patient is going to be feeling. So with him, you got established now. For future reference, you're allergic to Novocaine. I find that very reliable. I could predict you if I use Novocaine on him, he's going to have a hangover for the next 2 days. And lidocaine, I know we're going to be fine. I want to use the 1% on those. Do you have 1% here?
I'll look.
There we go.
We have a 1% xyloneural.
Okay, let me.
You want to try that?
Well, I think for practical purposes, we can assume it's going to be not allergic to this one too, even though it's got a little different lidocaine compound.
It's all 0.5%.
Now, what we want to be doing first is the tonsil injection, if it's okay with you.
Sure.
Please. I'm going to show you a little instrument that I used to use for a long time. And you don't use it anymore. There is from Welch Elrain about 1/2 to 3/4 of an inch. You slide it on the superior pole and one on the inferior pole. Now that usually goes in here on the, if this is the teeth here, just behind the last tooth on this side, fairly deep, much deeper than most people do it that do neural therapy, because they never look at the anatomy of the tonsils. But the tonsil is usually extending way down, and your lower position is fairly low down here, and you really have to take a good look at the particular tonsil, see where the lower pole is, and then go anterior to it where your needle slides in. And I would like to, before we actually do you, or we can do you first, and then we look at a few tonsils together, because I like everyone to get the
Where
correct.
was the upper pole in this one? Where are you saying the upper pole is? Are you saying we inject both spots or just the lower pole?
No, when the tonsils are in place, you do both poles. You do 2 injections on each side.
So the upper pole would be just about the middle of that whole arch.
Yeah.
Would be in the middle.
This piece of cake.
Oh, wait a minute, now we still have it done by the guy. Oh, I should
It's
have
where
a
the
chain
soft
on.
tissue joins the gum, is that where it's going to be?
Yeah,
I should have taken that off.
That disturbs the reading.
That's the one thing I really want everyone to get, because to tell you the
Yeah,
truth,
but
I've
we
been
can- you had it
injecting
on all
tonsils
the
for
time,
years
so the test
with very
results are
iffy
valid.
Relatively valid.
Because I followed my first instructor's teaching until I really on my own found out the importance of doing this right. It really makes a difference whether you do a procedure right or not. I never acknowledged it until I've learned over the years by looking at my failures basically. Okay, I'm first going to take a look at you. He's looking very suspicious.
I'm gonna get done. It might as well be by you.
Let me stand on this side. No, we don't need the light, Ed, because we got this light here.
Oh, you got that light now.
Okay. Okay, now he is the ideal patient to come look at. So I want all of you sort of to line up and sort of walk by here. And
First.
Where do you want to look? Well, when he does it, I'll move the table this way a little bit, okay?
So the lower injection point with him would be way down here at the bottom, close to the gum line, sliding the needle in. And the upper one would be up here.
And how deep again was the upper one?
The upper one in his case would be about 0.5 centimeter.
Okay.
A little more than a quarter of an inch.
Would you repeat that again?
The upper one would be just really at the upper end here going through the sail of the gum.
Use this as a pointer.
Thanks. The upper one would be right here. But more importantly, the lower one, I would slide the needle way down the gum line here next to the tongue in and go about 3/4 of an inch deep.
You say the bed goes in about 3/4 of an inch?
Well, for him, let me just kind of. I'm sorry, but you really have the idea. You know, like
You've had your tonsils out.
It takes
No.
You've had not.
Yeah, so the
Show it on your side.
the upper pole would be here, going sliding in through the front here.
Yes.
About a little less than 1/2 inch deep. And the other one, I would have to push his tongue out of the way, sliding it in right here next to the gum, pointing in this direction down.
Okay.
Oh, yuck.
Thank you.
It's very painless, the injection, by the way.
Yeah, well, I believe that. I just can't see where it is, and I wanna be able to do these.
You're gonna
Yeah.
feel where it is.
Yeah, I'm sure we get some other people. Yeah, so the upper pole would be injecting it right here, sliding it in, a little bit in and deep. If you see the local anesthetic squirting out, you know that you're in the empty space. You need to withdraw and go a little deeper. And the lower pole would be way down here, against the gum, sliding it in there.
Would you say his tonsils are large now in this situation?
Oh, my tonsils have been
Yeah.
scarred so many times, tonsils are trashed.
Yeah. But that's very,
Maybe
I
nice to
can
move it
guarantee
off.
that you're going to benefit from this no matter what.
No, it won't. You have to put it there.
No, we never take.
Just hold that.
Okay. Give him the shrapnel once a week. The upper injection is here, and the lower injection, sliding it down, would be here, about this angle.
And if there was no tonsil there, what's the...
Then you look for the stuff. We find somebody later on with no tonsil, because I want everyone to have it, so we go through the tissue.
You might hold this up so then two people can see, because it's blocking, so if you hold the light just a little bit further.
Okay, upper position is here. Yeah, and this needle position. Lower position, move the tongue out of the way, and about like this needle position. Not easy. Lower position is not. Okay, now your tonsils are gone now. Your tongue is in the way now. Okay. Upper position, this needle position, upper pole, lower pole, this needle position. Yes. Between the tongue and the gum. Going in about 3/4 of an inch. Two of you putting it together, please. Upper position.
Where then they can see it.
Okay, thanks. Upper position with the needle, lower position between the tongue and the gum line. This position. 3/4 of an inch. And two of you come around here.
Upper position, born again, she doesn't drink, she doesn't smoke, she's slim. Lower position between the tongue and the gum line, aiming at the lower pole of the tongue, about this area. But it's not an easy one. You need to have your anatomy in your mind. Well, that's where the needle slides in at the anterior palate. But you slide it in past the exhalator. Until you approximately at the lower pole of the upper position is here. About half an inch nice to reach you there. And lower pole would be going in between the tongue and the gum line here, this angle roughly. About 3/4 of an inch here. Reaching down very low. But please let me warn you, I was forced to take the streptococcus nosoc once a week, about 10 times. Drink one of those ampoules. I would give you one of those. The lowest pole will be about in this position. Yeah, no, you don't have to roughly know where it is. You see the tonsil there, you imagine in your mind how far it goes down. About here. Are you doing it? Upper pole, proceed to lower pole. I was saying, we're not going to go straight down. I think it's telling me the way again. Yeah, because that lower is the only one. So I'm just going to fold it. Why would you put in the strip in this? Wait, I can't see that. Because there's a chronically large tonsil at an age where it's not appropriate. Please do the bottom end, you know, when they shrivel. You go into the mandible. Okay. Slide in the mandible. Come both. Okay. Pull. Lower pulse. Way down there. Pull. Pretty good.
Figure that far back.
Very good, by the way. Yeah. Lower pole here next to the tongue. And it's different for everyone where the tonsils are. You find incredible variation.
Might have been checked for no, it's really funny. With his glasses on, you were strong, and there really was.
Why don't you stay here when we actually do the injection?
You're way out.
For the lower pole, about here.
Actually, at the root of the tooth, it's got that level that you're going into the lower pole.
It's improving, so you'll be able to see exactly where we And there's a thing, an element in the feeling is that you can feel where you are. Upper palm here, lower palm this is stretch nodes. I would not test it for it. All of these show consequences of stretch nodes. And they uniformly get well, so it's not even little milestones sometimes.
It's just I've got slightly chronic pain. Just too early.
We can use
It's months. I mean, that's almost part of it.
But I get the feeling sometimes I can do it.
Hold on there.
Margaret? Margaret? So now we do it quickly. It's not going to be bad. Okay. I promise. Okay, so we do the upper paw. Okay. Now lower paw.
Didn't hurt, really.
I know
I hate it though.
Yeah, I know. It's not a malignant procedure at all. Upper paw. Yeah, you can swallow it, by the way.
Great.
It's pretty moldy, doesn't it?
Just tastes awful.
Numbs the tongue.
He's trying.
And lower paw here is
Yes, I got it.
it's very deep.
Did you do it? The lower one? Oh, you did the lower one on that side? I didn't even feel that. The upper one hurts, but the lower one didn't bother me.
About half a ml at each.
So you go in about half a centimeter on the upper and the lower two.
Beautiful. Go ahead, hit it now. Take the light off, Ed. The head blows.
Okay, now let's go check your shoulder out.
Plug your neck at the shoulder. Finally got an angle.
Oh no, we already did it.
Yeah, you never make it in Hollywood.
So you're injecting both sides? Did you inject both sides? Yeah. Just one.
Okay, why don't we go sit back down again?
You always inject around the tonsil. You never inject
Never into
the
it.
tonsil, right? Because it's
That would hurt.
Difference is a scar. You go directly in the scar, in the center of the scar, but not directly in the tonsil.
That would hurt to go in the tonsil.
The tonsil. Okay, sit down and let's just finish up before lunch here. Please.
So you do actually have an improvement. I just want to show you, if you remember how he was very tight, and now look at this. See the difference? That something would have gone by totally unnoticed if you wouldn't have done a careful exam. Comes out of, I don't know if you remember the difference. Most people don't. But let's do let's do the other side. Other side is still better. So there was a definite improvement in his shoulder joint from doing the tonsils. And
Did you do both the tonsils right in
yeah. Now let's just kind of do some of the other movements. Is that still hurting? Do the external rotation.
on the other side?
There's also that's something I didn't mention before, we get some restriction on this. There's more range of motion, because we did have an improvement that I can verify objectively for myself, increasement in range of motion on internal rotation. Description of the sinus points, because you will need those